Hi, everyone. My name is Cindy Noyes, and I'll be the moderator for our panel discussion this morning on COVID and cancer. I'm the hospital epidemiologist and director of infection prevention at the University of Vermont Medical Center, and I'm an associate professor of medicine at the Larner College of Medicine. I'm so pleased today to be able to welcome my colleagues on this panel to discuss various aspects of how the pandemic has changed the way we practice medical care and what has been done to protect our cancer patients during COVID. We'll start with Dr. Shahid Ahmed, who is an assistant professor of medicine in the Department of Hematology and Oncology at the Larner College of Medicine and a medical oncologist at the University of Vermont Medical Center. Followed by Dr. Patty O'Brien, and she's actually the reason we're all here because she founded the Women's Health and Cancer Conference 24 years ago. Dr. O'Brien provides lymphedema consultation at the University of Vermont Cancer Center and also works with Steps to Wellness in the Oncology Rehabilitation Program. Dr. O'Brien is a breast cancer survivor who has participated in multiple national cancer research studies, including those at the UVM Cancer Center, and she's very interested in the long-term medical needs of cancer survivors. Dr. Michelle Sowden is the clinical director of surgical oncology at UVM Medical Center and is an associate professor at the Larner College of Medicine at UVM. She holds multiple leadership positions, including leading the breast transdisciplinary team at UVM-MC. Her clinical focus is on breast cancer with a specialty in surgical treatment of both benign and malignant breast conditions, including procedures such as oncoplastic breast conservation and nipple-sparing mastectomy. Dr. Elizabeth Watson is a co-chair of the conference this year. She is a radiologist at the University of Vermont Medical Center and an assistant professor at the Larner College of Medicine at UVM. A reminder to all, please use the Q&A feature to submit your questions at any time during the presentations, and we will answer as many as we can at the end of the discussion. Without further ado, I'll start on my presentation. Where today I have the pleasure of talking about some of the prevention measures that we've used to reduce the risk of COVID transmission in the healthcare setting. Some objectives that I had today were to really describe the process by which visitation, personal protective equipment, strategies, testing, and therapeutic interventions have been developed for UVM-MC. Further describe some of the non-pharmacologic interventions we've initiated to reduce the risk of transmission of COVID in the healthcare setting, both to staff and patients, as well as discuss the impact of vaccination. So just to set the stage, although we began preparing for COVID-19 in late January of 2020, really this hit home when the first patient from Vermont was confirmed to have COVID on March 7th, and the first patient with COVID-19 as the diagnosis was admitted to UVM-MC on March 10th. Within the following week, all elective procedures were canceled. Visitation came to a screeching halt. Ambulatory care was subsequently transitioned to complete telehealth model. And at this time, the state of Vermont actually could only run 50 COVID tests in a day. And we were running into national shortages of viral media, swabs, and chemicals to actually perform the testing. And this just goes to show that pandemics really are different than other types of mass casualties or disasters. By definition, they affect the entire world, and so federal and regional assets are generally unavailable. They last a long time, months, sometimes years, as we're seeing with COVID. Inevitably, there will be shortage of healthcare workers, either because they're ill themselves or taking care of others, or they're fearful of coming to work. There may be shortages of supplies, including medications, medication pumps, IV tubing, and generally vaccines won't be available in the beginning of the pandemic. And in normal times, hospitals and emergency departments are generally near or at full capacity, and we have limited surge capacity, which means that oftentimes there's a shortage of space and qualified staff to deal with a big uptick in numbers. When there is a crisis, incident command is initiated, and this is something that has happened at the national level, at the state level, within all the hospitals, and we were the same at UVMMC. And this is a standardized approach that helps coordinate a crisis response, where there's a hierarchy and people responsible, and the system can flex to make adjustments and modify response as necessary. Thankfully, last summer, we were able to disband incident command, but we've continued actually multiple subgroups that were convened during incident command to help modify and shape our ongoing COVID response. This multidisciplinary work group is composed of all sorts of different physicians, nurses, respiratory therapists, infection preventionists, supply chain specialists, industrial hygienists. It's a very broad group, both from inpatient and outpatient medicine, where we review the literature, make recommendations, and influence policy development, revise those recommendations on an ongoing manner, advise leadership, provide education, and really deliberate strategies when answers are not known. And examples of our groups that are continuing to meet are the biologic branch, therapeutics committee. We have an actual entire PPE steering committee and a visitation work group. So those folks continue to meet. We've really used a multimodal approach to risk mitigation, where we do everything from identify symptomatic people at the door, make sure people have the required PPE, that we have adequate access to testing. And we'll talk a little bit more about each of these. So the first is really trying to identify people at risk. And we've really tried to change the culture, particularly with staff, but also with visitors, that if they're feeling unwell or they've had high risk exposures, that they really should stay home and call their providers for guidance in terms of next steps. Should they get tested? Do they need to come to the hospital, et cetera? When people are entering the facility, we screen them at the door. Not only patients and visitors, but also staff do self-screening for symptoms, which is really important, because if someone becomes ill, we want them to be able to get the medical attention they need, and coming to work is probably not the right thing. There are also separate respiratory symptom triage for folks in the emergency department and urgent care when community transmission is high. Additionally, and this has been tough for all of us, because we are very patient-centered and want to be a welcoming facility, but certainly in the time of COVID, we know that physical distancing has been really important in terms of reducing the risk of exposure to COVID. And we've really done that here through capacity management. Initially, we completely restricted visitation, and this was not only just here at UVM, but was a directive from the state of Vermont. Thankfully, we've been able to liberalize those restrictions, but obviously capacity remains really important to reduce the population density of the hospital. We also delayed care, which was something that was really tough for all of us to do, but elective procedures were delayed until mid-May. And this was really to allow for an increased capacity were our infection rates to surge and people require hospitalization. And thankfully, we haven't had to revert to that, which is really important, because we want to continue to care for people despite the presence of COVID. One positive benefit, which I think Dr. OBrien is going to talk more about, is telehealth. And certainly we've had a marked rise in telehealth visits, which really helped providers continue to care for patients without having significant exposure both to staff and patients during that time. And actually, people really prefer this. And so I think that's something that will continue after the pandemic is long and gone. We spent a lot of time on PPE, and obviously there's no zero risk category, but the aim always is to keep the risk of transmission low. And you'll see the different masks and face shields that we use here in the hospital. I think one of the most visible things that we've enacted for people is universal masking, which means that everyone in the hospital, whether or not they are staff, patients, or visitors, are required to wear masks, which I think has not only reduced the risk of transmission of COVID, but also many of the other respiratory infections we deal with all the time. Access to testing, I'd sort of reminded people that, the whole state of Vermont could perform 50 tests in the beginning of this pandemic. Now we're up to, thousands and thousands of tests per day, which has been really important in terms of, being able to identify sick people sooner so that they can isolate and reduce risk of transmission to others. So that's been a real success here at UVM. Most importantly has been our vaccination rollout. And this graph is something that we're really proud of. You can see that the rates of infection for healthcare workers are in the black solid line per 10,000, and the risk in the cases of infection in the entire state of Vermont, the blue solid line. And these rates really mirror one another until there's a precipitous drop in our healthcare worker infection rates. And this coincides with about 4 weeks after our mass vaccination rollout began for tier 1 healthcare workers. So you can see that our infection rates in healthcare workers really decreased and stayed low and really mirrored community prevalence. Remember, not all healthcare workers were vaccinated at the time, even despite sustained cases in the community. And so based on thousands of hours of contact tracing, we're really proud that hospital acquisition of COVID for both staff and patients really have not been drivers of infection, and that our multi-pronged approach has been really important, including PPE, physical distancing, and now vaccination. And so, I think that, all of these have been really challenging interventions, but they need to continue. And, we're asking people for ongoing vigilance in terms of masking in the healthcare setting, staying home if you're sick, and calling for guidance. If a third dose or booster is recommended for you, please follow that guidance and test to isolate if symptoms arise. And with that, I'll end.
Hi, my name is Dr. Shahid Ahmed. I'm one of the medical oncologists here at University of Vermont, and I'm one of the genitourinary oncology specialists. And during COVID, we've had a COVID committee, and I've been a part of that. Cancer has really, patients with cancer have been affected by COVID, and we've been trying to minimize the risk in our patients. And that's what I'm here to talk about today, is cancer and COVID and how what we know so far. So initially, in the first 6 months to a year, we did not have a lot of data on what happens in cancer patients. But over time, this has changed, and now we know a lot more. There has been a lot of data that has been published in cancer patients, and so we know more. Number one thing is that cancer patients are at an increased risk of getting COVID. The incidence of COVID infections in cancer patients is higher than normal people. And the prevalence is also about 3% or so. So the prevalence might be a little lesser, but the incidence is higher in patients who are getting cancer. Specifically for hematological diseases, blood cancers, there is a higher chance of getting COVID infections. Secondly, the severity of COVID infections is more in cancer patients, and the mortality rate, the risk of dying from COVID infection is higher in cancer patients. So there's absolutely a need to discuss this and to do whatever we can to reduce the risk in our cancer patients. So COVID vaccinations have been very effective in the normal population. What about how effective are COVID vaccines in cancer patients? Well, we know that people who have had cancers and are not on immunosuppressive medications, they have almost a very similar rate of making antibodies to the COVID vaccine and for the vaccine to be effective. But folks who've been on chemotherapies, or who've had a stem cell transplant, or who've had their immune systems lowered because of chemotherapy, the chance that the vaccine might work for them is a little lesser. The reason being that you need a healthy immune system to mount a response to the COVID vaccine. And so therefore, it is so important for people who are who have cancer to get the vaccine, because there is definitely some benefit that you're getting from there, but also very important to keep on masking thereafter. So what about the side effects of the COVID vaccine? And do people with cancer have more side effects? Well, thankfully, we know now that there is data out there that suggests that the COVID vaccine is very safe in cancer patients, and there aren't any increased risk of getting any side effects from the COVID vaccine. So definitely very important if you're a cancer patient and you've not had a COVID vaccination, to consider getting a COVID vaccination because it will provide protection. The side effects are minimal, and unless you have an allergy to some of the substances in the COVID vaccine, apart from that, there are very few contraindications for getting the vaccine. A lot of cancer patients have received the COVID vaccine, and now the next question is, what do we do about the booster? So recently, there has been a committee formed at the national level that has come out with some recommendations, and they're saying that at least at this point in time, patients who are 65 years of above should get a third booster, and then anybody else whose immune system might be suppressed or who has a high risk of getting COVID, whether through occupation or because of their health, should be considered for a booster. The timing for the booster is not truly known, whether 6 months is necessary or 8 months to have elapsed from the last COVID vaccination. But the guidelines so far, and we're looking to the CDC towards it, are that after 4 to 6 weeks of your prior vaccination, you could get a third booster. Certainly in our stem cell transplant patients, we're doing it much sooner in order for them to get their antibodies developed for that. So most important, regardless of getting the vaccine, is to continue masking and for social distancing, as Dr. Noyes kind of talked about. This has been probably the most important thing in our clinic when patients are coming in and we're giving them infusions for chemotherapy. It has been most important to kind of do that. But I understand that that also kind of takes away from the experience of a physician talking to the patient about their cancer and about life-altering treatments, and not having any visitors with you at that time. So telemedicine has changed that a little bit, and we've been able to kind of get the family members of the patients in on conversations. But and in the last 6 months, we've also kind of increased the number. We've kind of been able to get at least one visitor per patient in to have discussions. The pandemic has had a massive impact on cancer patients. There are patients who've had delays in their care where they did not seek help for some reason, or where symptoms have been, not where biopsy has been delayed. And therefore, we have seen that people come in with more aggressive disease or later down the road disease, and it has been harder to treat. So thankfully, we're seeing now that most of the population is vaccinated, and we're able to kind of do more of these testings sooner rather than later. And so it is important that if you have any new symptoms, any weight loss, any appetite changes, any new bone pains, or any new masses that might be growing, to get that checked and to get the appropriate care in the right clinical setting. With that, this is, I wanted to talk about the current status of COVID vaccination, as well as the pandemic in cancer patients. And I would be happy to answer any questions. With that, that concludes my presentation. Thank you so much.
Hi, I'm Patty O'Brien, and I'm here to talk to you about the telemedicine visit. This pandemic has forced us to rethink the way we do lots of things. And one of the things it's forced us to do is really reevaluate how we deliver care to our rural patients. It's really clear that this pandemic has caused much pain, suffering, and loss of life. But like a war, a pandemic can also force us to change and think about doing things differently. Sometimes those changes can make us stronger and more resilient. The increase in video medical care, in my personal experience, is one of those positive outcomes that has made our healthcare system stronger and better. I'm kind of an old physician. I've been doing this a long time, and it's hard to get people to change. But if you had asked me 2 years ago, could I deliver medical care on Zoom or by video, I'd have said no, no way. Now I love providing medical care on Zoom for appropriate problems. It has saved my patients hours of coming in on roads, driving for care. It has allowed me much faster access to them, to talk to them about what they're concerned about, so we can triage and figure out who needs to come in and who doesn't need to come in. One of the things I love the most about it is that it allows me to go into their living room and meet with their families in their space. And I get to meet with the whole family, and it's given me a much better understanding of family dynamics. So instead of them driving in hours, being uncomfortable, being in my space, in my exam room, under my rules, now I'm going into their home and meeting with their family. Which I really enjoyed that. Previously, I never thought I could ever examine a patient on Zoom, but I've learned to do that. And to do that, I've had to engage whole families to help me do the exam. So they're moving cameras around to show me a rash on someone's back. Sometimes even the grandchildren are involved because, let's face it, kids know technology better. And they've helped set up the Zoom. They've moved the Zoom camera down to grandma's ankles so that I can see if her ankles are swollen, or does she have edema or some redness there. Talking to folks about getting simple tools. So this is just a very simple oxygen monitor that allows patients to tell me what their oxygen saturation is, what their heart rate is. So working with families to figure out what tools do they need at home so that I can collect more data on their chronic diseases engages the whole family in understanding what we're looking for. I also work with the Steps to Wellness program, which is a program sort of like cardiac rehab, except it's for cancer patients. And it was always done in a gym. Well, COVID came, and in one day we had to close the gym and go to a remote program. And so we had to relearn how we were going to do a remote program. So we first started off with just videos, and people would watch videos, but then we redesigned the program to figure out what patients were safe exercising at home. We had to come up with a new workflow. We had to train our staff to use new technology. We had to buy new technology. And the participants were great. They really helped us design this program. Some of them had been in the gym and they knew, what it used to be, and they helped us change it into something new. So eventually we hope to be able to go back into the gym, but we're now going to keep the remote access because it allows so many more people to participate in a wellness program. So we've learned a lot doing this remote care, and continuing remote care is a positive part that's come out of the pandemic that we need to learn how to put that into our new systems of care. So that's going to mean new licensing laws, new reimbursement laws, a change in expectations. But what I've seen is this allows me to provide better care for my rural patients, provide better access. And so I'm hopeful that we will design this into our redesigned post-COVID healthcare delivery system. So I expect most of you have participated in a remote visit. And I urge you to get involved in the process, because this is going to be a process. If you like having Zoom video care, you need to talk to your doctors and say, hey, please make this part of future care. Talk to your insurance provider and say, please make this part of future care. Pay the providers to do this. You're also going to have to work on a state level and a federal level to change the laws that govern video care. This is a very complex process. Healthcare is regulated on a federal basis, on a state basis, and by multiple reimbursement systems. So if you want video visits to be a part of your future, you need to use your voice and tell people you think this technology is important and you want to expand access. So as I said in the beginning, I didn't think that video visits would work. But I am now a real believer that this is a technology, just like we've learned lots of technology about vaccines, and it's changed our public health system. Video visits need to be a part of how we do things in the visit. I hope you're learning a lot from this conference today. In the past, this conference used to be done at a big conference center. People would drive long distances. We'd have 700 people in one big conference center. Obviously, during COVID, we had to change the way we did this. And last year was our first year doing this on Zoom, and we learned a lot. We learned that a lot more people could access it, not only the day of the conference, but certain lectures. Over 1,000 people would watch that lecture after the event was over. And people will be able to do the same thing with these lectures. They're going to be able to watch these lectures by going to the Cancer Center webpage. They'll end up being hooked up to YouTube, and your friends can watch it later on. So if you've learned something today and you want your friends to learn it, you can tell them to watch it afterwards. So I'm really happy that we're able to bring you this conference on Zoom. And I want to thank you very much for allowing me to be a part of your day. And hopefully I've been able to teach you something. Thank you.
So hi there, I'm Michelle Sowden. I'm one of the surgeons at UVM MC. I specialize in breast cancer treatment. And I was asked today to give a real world example of what it's been like being a patient in COVID-19 and give a clinical example of the repercussions of delayed screening. So I think we can all agree that delayed screening can happen for a variety of reasons. You may have other health issues going on. Someone in your family might have health issues that you're taking care of them. Life gets busy, and so sometimes delays in screening happen, and we know they can be pretty impactful. But this was a delay in screening that happened for almost everyone, and there were a variety of reasons that things were delayed. It was both the hospital closing things down, but then in general, we found our patients to be pretty fearful of coming in and being seen. So the patient that we're going to discuss is a 56-year-old who had self-palpated a nodularity in the lower aspect of her breast. She personally had a history of fibroglandular breast tissue, and so wasn't really concerned when she initially felt it. She thought maybe it was a cyst, and she really did not want to come into the hospital or even into her primary care doctor's office during COVID-19. Her last mammogram had been in January of 2019 and was completely normal. And she had planned, her next one was scheduled for late February of 2020 and ended up being delayed because of COVID. As time went on and she started to feel this area change, she looked in the mirror and noticed that the skin was dimpling over top of it. So this is her imaging, and what you'll see on the far left was her mammogram in 2019, which looks normal. And then in 2021, in the summer of 2021, she now has a large mass in the breast, and this correlated well to the area that she was feeling on her own self-exam. She had an ultrasound performed, and I know that not everybody out there is reading ultrasounds all the time, but this is grossly abnormal. The tissue should look like just very uniform, and this is a large, concerning spiculated mass in the breast. And so this underwent biopsy and came back as a cancer. The impact on her was that the mass had grown quite large and involved most of the 6 o'clock position of her breast. As a breast surgeon, this is a particularly challenging spot to operate in the breast because if you take a lot of volume out of the lower pole of the breast itself can become quite deformed. You lose the natural ptosis, which is sort of the droop of the breast, and it can leave patients looking very disfigured. That said, this patient had a very strong desire for breast conservation, and we love to be able to achieve that goal if somebody's very invested in it. But a normal lumpectomy was not an option at that point because the cancer had grown large enough that we couldn't achieve a good cosmetic result with normal lumpectomy. So this required that her procedure was done in conjunction with a plastic surgeon. This allowed us to have breast conservation with a nice, acceptable cosmetic result. It was a significantly larger surgery with a much more extended recovery, but did achieve the goal. Now, certainly I am not, I can't predict whether or not this would have been what she needed if we had been able to screen her earlier, but certainly I don't think that the delay was helpful. The surgery that we did is something called an oncoplastic reduction. Oncoplastic reductions are where you have an oncology surgeon like myself working in conjunction with a plastic surgeon and taking larger chunks of tissue out of the breast and reconstructing the native breast tissue. Her cancer was at the 6 o'clock position and was very large, and so required an inverted T mammoplasty and was achieved with a really excellent cosmetic result. When we have to transition from a standard lumpectomy to an oncoplastic reduction lumpectomy, the surgery goes from 1 hour to 3 or 4 hours. This usually at our institution is done in 2 stages, where I performed the first stage and we closed her up and got her pathology report back about a week later to make sure that her margins were clear. And then the plastic surgeon did his portion of the case to do the reconstruction. It's still done as an outpatient surgery, but the recovery is significantly longer. It also requires that a procedure is done for symmetry on the opposite breast. And so instead of having one small incision on her affected breast, she went forward with bilateral reduction procedures on both sides. This, however, is an excellent plan B in a patient who has a large cancer and wants to salvage their breast, and allowed us to take care of her in the way that she wanted to be taken care of. Certainly, I think that her fears around COVID and the delays in screening led to a much larger cancer, but I do believe that her cancer outcomes are still going to be excellent. And that's the end of my presentation.
Hi, everybody. My name is Elizabeth Watson. I am a radiologist here at UVM, and today we're going to be talking about COVID-19 vaccines and breast imaging. So lymph nodes are part of the immune system, which helps the body to fight bacteria or viruses that make you sick. we all have hundreds of small, round, or bean-shaped lymph nodes, which exist all over our bodies. Most are spread throughout the body, but some are actually found in groups like in the neck, the chest, and under the arm in the area called the axilla. Lymph nodes are connected to one another by lymph vessels that run throughout the body. When there's a problem in your body, like an illness or an infection, your lymph nodes can swell, they can enlarge and thicken, a process that we call adenopathy. It's a sign that lymph nodes and the immune system is trying to fight off a disease process. Many things can make your lymph nodes swell, like infections, like the cold or flu. Much less often, it can be a sign of something more sinister, like a cancer. Rarely, vaccines can actually also cause swollen lymph nodes on the side in which it was administered. Axillary adenopathy has been reported with many different vaccines, including the influenza vaccine, the HPV vaccine, and the COVID-19 vaccine. So that's what we're going to be talking about today. Lymph nodes are commonly seen on mammograms. The image on the left shows a normal right and left mammographic view. And you can see by the arrows, we see lymph nodes that are up in the armpit and the axilla. And these are very normal in appearance and very commonly seen mammographically. We also look at lymph nodes on ultrasound. And if you look on the right side of your screen, you can see some ultrasound pictures in the red circles here. And this is what lymph nodes look like normally on ultrasound. These are very normal in appearance. Axillary adenopathy in women with an otherwise normal screening mammogram is a really rare occurrence, reported in about 0.02% to 0.04% of screening mammograms. The reported malignancy rates of having axillary adenopathy in a normal mammogram are highly variable. The few published studies that we've seen include women with both unilateral and bilateral adenopathy, and malignancy is often due in these cases to non-breast primary cancers like lymphoma. However, higher rates of axillary adenopathy have been reported with the administration of COVID-19 vaccines. As national vaccination efforts were underway, women with a recent COVID-19 vaccine often presented with diagnostic workups for newly palpable axillary adenopathy. And they also were found to have axillary adenopathy on routine screening studies, whether they're mammograms or ultrasounds. For patients who received the Moderna vaccine, we know that axillary swelling or tenderness was found in about 11.6% of patients after dose 1, and about 16% of patients following dose 2, so relatively common. The lymphadenopathy usually occurred in the arm and the neck about 2 to 4 days after the vaccine and lasted for a mean of about 10 days. And usually this process was on the same side that the patient did receive a vaccine. These images right over here on your screen show not only that we see adenopathy, as you saw on some prior pictures mammographically, but we also see them in other modalities as well. These are CAT scans, and what we're seeing here in the left axilla are some enlarged lymph nodes that the patient was noted to have on CAT scan about 7 days after the vaccine. This patient is a different patient, was found to have an enlarged lymph node on CAT scan about 13 days after their dose. And this patient at the very bottom first had a CAT scan before the vaccine was administered, and then a repeat CT was done, which showed 8 days after the vaccine that those lymph nodes did indeed swell. So as more people became vaccinated, we saw more axillary adenopathy on mammography. And when we see it mammographically, we usually have to get additional imaging to further work it up, which usually includes a breast or an axillary ultrasound. And oftentimes we ask the patient additional questions about their medical history and any recent COVID-19 vaccines. On that additional imaging, if the lymph nodes look totally normal, then no follow-up was actually needed at all. If the lymph nodes looked enlarged and the patient verified that they did actually have a vaccine in the same side as the findings, we began to recommend a short-term follow-up in about 4 to 12 weeks. If on the follow-up imaging, the lymph nodes didn't normalize, then at that point, we would recommend a biopsy of that lymph node. And this is a real case that we had at our breast center. You can see these images over here on the right side of your screen. Initially, the patient presented with an enlarged lymph node very shortly after the COVID-19 vaccine was given on that side. And then sure enough, when the patient came in 1 month later, the lymph node had completely normalized in its appearance. And so no further follow-up was needed for this. We realized that these workups and follow-ups are a huge cost for patients and the medical system and can often cause a great deal of anxiety for patients. We were anticipating a tsunami, so to speak, of patients presenting with symptomatic axillary swelling, as well as screen-detected axillary adenopathy. Therefore, we knew that we had to make some changes in how we scheduled screening mammograms. So we decided to schedule screening mammograms either prior to the patient's first COVID vaccine administration or asking the patient to wait 4 to 6 weeks after the second dose. If the patient presented with unilateral axillary lump or swelling, we asked if the patient had had a recent COVID vaccine on that side. And if they did, we considered delaying their images and recommending follow-up clinically in about 2 to 4 weeks. We also made sure to explain to patients that axillary adenopathy is a normal reaction to a vaccine, a sign actually that their body is making the appropriate antibodies. Then on the follow-up imaging, if the lymph node enlargement had resolved, then no further workup was done. If adenopathy was still present in 4 weeks, then we usually recommended that the patient proceed with the additional imaging evaluation. We did not want to delay any imaging for clinically suspicious breast or axillary lumps. So in sum, we strongly believe that it's important for all patients to be vaccinated to mitigate the risk of COVID-19 infection. And we also strongly believe in screening for breast cancer. So the extra effort that's required to separate these two necessary health promoting endeavors will save costs, reduce anxiety, and continue to allow patients who have non-transient breast or axillary problems to be seen and cared for in a timely manner.